I would like to welcome and thank you all for joining our last webinar for this academic year 2022. Professor Mini Singh and Dr. Tamara Griffiths will be delivering an important, very interesting topic for us: supervision or mentorship. What's the difference? Maximizing my development as a dermatologist. Before we proceed with the talk, I would like to introduce the meeting host for today, which is myself, Dr. Rifenze Tobia from South Africa, Dr. Ashwan Tai from Australia. I will quickly run on our housekeeping rules. Your audio will be muted and the camera will be turned off for the duration of this webinar. If you have any question or comments, please share via the chat function and our meeting host will share this with the speakers at the end of the webinar. We will also be sharing some information about GLODEM Trainee Committee in the chat function. Is it supervision or mentorship, formal or informal, hierarchical or non-hierarchical? Butterworth defined it as an exchange between professions or enable the development of professional skills. Button and Lona defined it as to facilitate learning or relation to life practical issues. So it is an honor for me to introduce Professor Singh, who is a professor of medical education and honorable consultant dermatologist at the University of Manchester. She was awarded the prestige Principal Fellow of the Higher Education Academy for her strategic leadership in both undergraduate and postgraduate healthcare education. She is Associate Director for Teaching and Learning for the University of Manchester Medical School. Professor Singh sits on multiple national and international educational committees, either as a chair or member, including the International Dermatology Education Alliance, undergraduate work stream for the British Association of Dermatology, and the UK Clinical Reasoning in Medical Education Group. She has a keen interest in the science of clinical decision-making, having delivered multiple talks, workshops, and CME programs on the topic both nationally and globally. Professor Singh, you are welcome. Over to you.
Thank you very much. I'd like to also introduce my colleague, Tammy. You've just turned your screen off, we'll put it back on, who actually has been my mentor through my career as well. So I'm really glad to be doing this workshop, and welcome to everybody. Thank you for giving us this opportunity to the Global Training Community. So Dr. Tamara Griffiths is a colleague of mine, works in the International Dermatology Education Alliance, but actually is a real forerunner in the UK around postgraduate training, particularly has done a lot of work of that, and currently is the director of the British College of Dermatology. Tam, do you want to just say a few words about your background? Oh, you're mute.
Orion, thanks for those kind words, and also really delighted to be here. Very happy to contribute to the GLODERM program. Education is universal, and it's something we need to share good practice in dermatology and amongst all healthcare professionals globally. So really thrilled to be here and very happy to be invited. Thank you.
Thank you, Tammy. So what we're going to be doing is I'm going to just share my screen and swap over some files, if that's okay with you guys. There you go. Should be all seeing that now. So yeah, it's an interesting topic, this one, and why we actually chosen it. It came out of a discussion with the GLODERM committee with Dr. Freeman and others about how supervision and mentorship are viewed in different parts of the world. And what we'll be doing is we will be encouraging you at certain points to put your views in the chat. So please be ready to do that. so that we can hear your views, because this is going to be more interactive. It's not just about passing information to you. So first of all, I'll introduce why we're doing it, Dr. Griffiths and myself. We are part of the International Dermatology Education Alliance, and really this has been set up, and you can see by the names of it, as a global group who's there, that the primary aim is for us to develop the educators of future in dermatology and provide support to them so that they can have excellence in their teaching. I think the bottom line is increasingly understanding your role as a teacher, understanding your role as an educational leader, and even having that aspiration to be one does have a huge benefit to not only the people that are being taught and the residents, but people in society. And that's where we want to move to. As with other areas in dermatology, we want to be at the forefront of this. There's a little bit of work to do on that and for our awareness of it, but that's why we set up the International Dermatology Education Alliance. And it's on behalf of the group that is represented here and all the names here that Dr. Griffiths and I are giving this workshop. So first of all, I want to ask you, who's in the room? Could you write in the chat where you're from and whether you're either supervisor, mentor, supervisee, mentee, or have leadership roles in education? It'd be lovely to see that. If I can just give you a minute to do that. Thank you, Chitna. So we've got a mentee, research fellow, mentee without a mentor. I like that idea, Monty. Let's see at the end of it whether we can help you with that. Great. Thank you, Dr. Singhal. So a mentor. So we've got a little bit of a commendation coming through. They're all starting to come through. Interesting, Dr. Mansour, it'll be interesting to see by the end of it whether actually, though you're not either formally, do you actually play that role anyway? So great. And we've got Dr. Singhal listening in about the residency program. So it'll be really interesting to hear from yourself. So lots of perspectives there. So we've got some of the breadth of mentor-mentee, opportunities to be mentor-mentee, and maybe people are actually doing informal supervision or mentoring or mentee and they don't realize it. Okay, so what are we going to cover? We're going to cover why there's a need. Why are we actually discussing this? Why did we come up with this topic? What's the gap? What is supervision in medicine? What is mentorship? Is there a difference? And actually later on towards the end, we're going to just highlight some areas, hopefully through the process of how you can enable yourself to develop in the way you need to as a dermatologist, in the way you wish to, and to have some direction and ownership of it. So that's what we'll take you through. So what's the purpose of all this? Well, the purpose of this is surely to achieve success. However, success is very personal and it should be defined personally. In this space in medicine, success for our residents is potentially, we're talking about actually becoming a dermatologist. But if you already are a dermatologist, what does success look for you? You've passed those exams, you've achieved that specialist status and that experience. But as doctors, we continue to push our boundaries. That's what we do. And there is absolutely no way we can achieve success without, I really like this picture because I think it actually comes out of a business journal, out of Forbes, but it really does highlight that success is defined by our failures, by our obstacles, our mistakes and our difficulties, by having perseverance and tenacity. And that can be sometimes hard to maintain. And that is where I think mentorship and supervision really come in. So why is there a need to discuss things? Because in the world of medical education and what is out there in the literature, and there's now a huge base of understanding, particularly from the cognitive psychology literature, about the education of clinicians. We have been, and we are in many parts of the world, still in the apprenticeship training model. See one, do one, teach one, very familiar to us all. But the era is changing. And if you look to North America, Canada, UK, Australia, we're actually moving to something called a competency-based education model. And that requires much more formalized structures. So I've given an idea of a diagram here. You can have a whole separate conversation about competency-based education model, but essentially the experiences we're talking about with familiar to you will be that there are assessments for trainees and residents, that they have to meet certain gold standards, and those gold standards are set in stone. They are not made on a clinical judgment by someone in an apprenticeship model where we just went through things. Yeah, you seem okay. We've had a few conversations. Apart from the sort of membership exams, within the clinical experience, there were no formal structures. Now we're seeing that there's programmatic assessment. So you're getting workplace assessments. You're actually, the output they're aiming for is, can this person do the job to the level they are expected? Rather than, can they just do the job? They've passed the membership exams, therefore they're good enough. What that's brought in is formalized assessment, formalized roles, formalized accountability, and as a consequence, supervision. And actually both supervision and mentorship in medicine are really, really quite new. Supervision is barely a decade old. So there's a real need for us to understand them and understand the differences, the benefits and disadvantages of both. And to ask yourselves, which role am I in? Because commonly we find that supervision and mentorship are interchanged as one and the same thing. And I hope to show you by the end of this workshop, Dr. Griffiths and I, that they're not, and there are nuances to them, and understanding those will help you in your progress and your aims and aspirations. So why has outcomes-based competency come in, and why is it going to continue to spread around the world? The reason is outcome-based competency is focused on patient care, on safety, and output of patient health. Given the pandemic, we are now, it's very clear the global world of healthcare, the global physician we need to be, because our patients come and go from all over the world, bring in infections and other diseases. They are so mobile. So we are being required, and we are accountable to make sure that we have the sufficient skills, applications, and maintain them. As a consequence, outcomes-based competency has now come into the fore. And I think really in the next decade will spread throughout the world, because the world needs health workers that can do the job and show they can do the job. It saves money, it saves time, and it retains workforce. And that's why it's being promoted so heavily. The other aspect of outcomes-based medicine is it's very different to the apprenticeship model, which was you watched, you saw, you did. This is about the learner, and the learner makes decisions, the learner drives changes. And that's really important to understand as supervisors and mentors, because the learner has an accountability. The learner should be driving the inquiry and the discussion, and therefore it's a collaborative discussion, leading to creation of their own ideas and understanding of their role, their knowledge, their skills, and their abilities through reflection. So I'm going to hand over now to Professor Griffiths to talk about the supervision side of things, if I may.
Brilliant. Thanks so much, Mini. That was a great way to set the scene. So we're trying to distinguish supervision from mentorship, and I'm going to be discussing with you supervision. What is supervision? I'm going to talk about effective practice. What are the challenges and unmet needs? And this is a section I'd like you all to try to contribute to in the chat. What are some of the barriers to your own experience as a supervisee and as a supervisor? And also, I want you to reflect on your own practice as you supervise juniors. Next slide. So supervision is defined as the provision of guidance and feedback on matters of personal, professional, and educational development in the context of a trainee's experience and providing safe and appropriate patient care. So as Mini explained, underpinning all of this is safe and appropriate patient care. And there are different components to clinical supervision, and this will be familiar to you. Oh, there's the educative component, so you have to learn the content of the competence. You have to learn and have good knowledge, but you also need to be supported throughout your as a supervisee. And then you also have to be managed. So the supervisor has to manage the workplace-based assessments, the progression, and that side of things. So there's the formative, restorative, and normative components to clinical supervision. Next slide. So we've got the same definition up there. There's actually there's a lot in that definition, so I'm going to break it down a little bit. The supervisor-supervisee should have a longitudinal relationship, and a named supervisor should be allocated for best practice. It differs from teaching, which is really just the flow of knowledge, but it also contributes to the supportive and managerial components of our practice. patient safety I've talked about, but also it's the trainee or the resident safety. So if you look above in the definition, it says development in the context of a resident's experience. So you should be supervised appropriately to your level of training. So there's safety for the resident as well as the patient. You need to have continual feedback so you can alter your practice and learn from it, change your behavior. Your practice and progress needs to be monitored and finally assessed, because ultimately when you finish your training, you will need to have accrued enough evidence to demonstrate you are able to perform all the tasks you need to perform as a consultant dermatologist or attending dermatologist in an unsupervised and independent fashion. Next slide. So monitoring the progress. And as was intimated, the concept of supervision is relatively new, and although it's critical for the development of healthcare professionals, it is the least researched and supported aspect of medical education. Next slide. So we are going to focus on guidance and feedback. Feedback, you know, as trainees, good feedback, constructive feedback is like gold dust. It can make you improve your practice, change your behavior in leaps and bounds without feeling defensive. It can be viewed as constructive and helpful, but the feedback needs to be clear, focused, and timely. It can be informal, just in clinic, quick feedback, but it also needs to be formal through an annual appraisal and review. And it should address the positives as well as areas that need to be developed further during these feedback sessions. Next slide. In this definition, supervision involves personal, professional, and educational development. It overlaps a little bit with mentorship, but Professor Singh will go on to explain the differences of mentorship and supervision. In this context, the personal development aspects really involve your interpersonal skills, the way you are, your personality, and how you can maximize that to use effectively in a team, communication and leadership skills. It focuses on your professional behaviors and attitudes, as well as your capabilities in research, teaching, and in management. Next slide. But underscoring all of the purposes for supervision is patient care. This underscores all aspects of supervision. We know that effective supervision leads to positive effect on patient outcomes, and lack of supervision is actually harmful to patients. So if you talk to your old professors, they say, oh, back in the day, we just got on with it. We weren't supervised. And I learned a lot from that. That's true. It is one way to learn, but it's not the best way to learn because it's not the most efficient way to learn, and it actually can cause patient harm. So we understand now that a degree of supervision is very important compared to the apprenticeship system. Next slide. So I'd like you now to sort of reflect on your own experiences. I know some of you are no longer in training, but when you were in training, or those of you who are still in training, reflect on your own experiences. What's it like to be a trainee in your department? What are some of the challenges and barriers for you to feel like you're effectively supervised? Also reflect on your own practice, because you will have acted as a supervisor in some capacity for a medical student, for a registrar more junior to you. So reflect on your own practice of supervision. Have you been formally taught on some good practice, good behaviors? What skills do you need to develop when you reflect on your own practice, and maybe compare your own personal practice? How has that influenced how you will go forward? So it'd be great if people could just type in the chat some of the barriers. And I also know culturally, the concept of education and teaching and supervision is very different in different countries. So it'd be interesting to compare and contrast different panelists, different attendees' experiences, as this is a international group of attendees. So please type in some of your experiences in different countries. I'll just try to get you started. Some countries are more hierarchical, where a student may feel afraid to ask a question. They're less open, so that power balance might be a bit of a struggle. time. So it'd be great if some of you could type in the UK, lack of consistency between a single name supervisor and supervisee. Thank you, Monty, for contributing. Overbooked clinics, no time, parallel pack lists, absolutely. So particularly during the pandemic and
yeah. I mean, I think that's an interesting one that Monty's brought up, and it allows us a point of discussion while others type in. Is Monty, you're describing specifically clinical supervision as opposed to educational supervision. Tammy, could you elaborate on what you see are the differences between those two?
Sure. So clinical supervision is sort of the one-to-one supervision. When I have a clinic and I've got loads of different trainees or students in my clinic, I'm providing clinical supervision directly for the patients that we see together. Educational supervision is a little bit higher up in the hierarchy. So if you remember the concept of supervision, there's knowledge, there's pastoral support, and then there's managerial aspects. So the educational supervisor contributes to the pastoral care as well as the managerial aspects of progression and assessment more than a clinical supervisor. So certainly in the UK system, now I agree, I acknowledge it's different in different countries, but in the UK system, a registrar or trainee will have a named educational supervisor that hopefully will be the same person over the 4 years of training. And this is the person that helps support the trainee, think about what they might want to do if they want to develop a specialist interest, talk to them about problems they might be having, providing the pastoral care. But in addition, they're the ones that have to write the report, to collate all the information from the clinical supervisors, try to develop a picture of whether or not this trainee is reaching his or her milestones, and where areas, strengths are, weaknesses, and then they can try to suggest different opportunities so those weaknesses are filled. So develop a plan so the trainee stays on track throughout the 4 years to reach the goal of evidencing capabilities or competencies in all the areas required. A clinical supervisor is really more, can change around because a trainee might do different clinics and might have different clinical supervisors throughout, they will have different clinical supervisors throughout their training. So the clinical supervisor is more one-to-one on work in the clinic, where the educational is sort of more managerial and pastoral as well. I hope that helps. But I would agree with Monty, issues with time. There's always a tension between service and training, and getting that balance right, you know, is complex and needs support from management, educators, supervisors, you know, so there's a lot of pieces in that puzzle to get the balance right. I mean, I don't think there's an easy answer, Monty, but we have to keep pushing to emphasize the balance between service and training, because it's easy for managers to really be focused on service. I hope that's helpful.
Yeah, it is. We're getting some interesting stuff. Dr. Mansour's come in with a really interesting point, and it's lovely to see the different conversations. So Dr. Mansour, so different experiences can limit true guidance. Supervisors often think of their own career pathway, both a pro and a con, because you get their insight from their experience as well. And then Monty's asked, I wonder if the same tension exists in other countries. I think Dr. Mansour and Ashish, you made a really, really good point about that. And I think that's why when you have such crucial progress decisions to make, because supervision is all about the progress, you can prevent a resident progressing in your supervisor role. Understanding the limits of the supervisor role and making it formal is what you've seen to address that challenge in countries like America and the UK and Australia and New Zealand. And I'd love to hear from those in the audience who may not be from those countries. If there's something, do you see a change in that supervising, the more formality coming around? So supervisors need training themselves, because you need to address some of those tensions. And Dorian's put in Tanzania, we have very few dermatologists, so clinical supervision is almost in existence. So Dorian, I would argue that it does exist, it just doesn't exist in this formal way because they're very few. So you've got an issue with resource of enough people to actually deliver on that. And it's not as formalized. And Dr. Singhal says it's not very well structured and it's very informal. The post-MD senior resident, yeah. So the question I ask you all is that you highlight to me a gap, because what you're actually saying is we don't have those things, but are there ways we can support dermatologists so that when they are supervising, they have some framework or structures within which to deliver their role as supervisor. And this is not specific to dermatology, but actually now the evidence is emerging on the impact on patient care. So I put a challenge out there to say, why aren't we? And let's do something. You can start small and you can build it up, and start reading the literature around supervision. What is it? Why is it? At the end of this talk and this webinar, we do have some references which can also be sent to you by email, I'm sure, Griffiths. So thank you very much for sharing those things. Tammy, I'll move on to the next slide.
Yeah, thank you. So supervision, we acknowledge that it's important and effective, but as we've, as you've demonstrated as attendees, it's highly variable within a single program, within a single country, and certainly internationally. So I'm going to review with you how supervision should be developed, and maybe you can use this literature as ammunition or as data and evidence for your own programs if you're in a country where you feel supervision, the concept of supervision is really in its infancy and not very well understood. So again, we're all scientists and we respond to data. So if there's data for clinical practice, your supervisors, your consultants will respect that and absorb it. So the concept is we also have evidence for good educational practice, and it's an opportunity not to be personal for you to say, well, you're not really supervising me. I have no, this is terrible. No, it's just you can present in a very objective way. This is the data for good education, and dermatology practice is clinical research and education, and it's a way to kind of move that forward, and you can actually lead it in your department to a degree, even if you're still a trainee. So supervision should be structured with agreed learning objectives. We understand the relationship strongly impacts effectiveness. There needs to be continuity between the supervisor and the trainee or the learner over time. The resident or the trainee controls the product and the process of supervision. So ideally the trainee will get to choose or have some input into who their supervisor is. And the learning outcomes can be discussed, and a strategy, how they can be achieved, can also be discussed and negotiated so it's suitable for the trainee. That buy-in from the trainee is critical, and there needs to be reflection on both parties. So the supervisors also need to reflect on their attitudes and behaviors if they're only trying to push forward their own research agenda. Maybe that's not the best way to be an educator. So it's raising the standard and the attitude towards education. It's not just a poor relation, but it's something very important. So the strap phrase, we understand bench to bedside in terms of translational research, but this is classroom to clinic. It's the same thing, it's translational education. So using evidence-based educational tools to provide the best education, which will put out the best dermatologists, therefore be best for patient care. Next slide. So positive behaviors, we need to give direct guidance on clinical work, and we need to link the theory to practice. So rather than making a comment, oh, you're doing great, you really need to make a direct link with something the student did in clinical practice and back it up with theory. We want the supervisor and the trainee to engage in joint problem solving, particularly when offering feedback. So it's good if the supervisor asks the trainee, how do you think you did? What do you think are the pros and cons? The supervisor needs to provide reassurance and act as a good role model. Obviously, good interpersonal and teaching skills, and the supervisor needs to be clinically competent and knowledgeable to have credibility. Next slide. What are bad behaviors? Low empathy, failure to support, failure to understand the trainee's concern, not teaching, being indirect, not being very vague and not being able to speak concisely when providing feedback, being intolerant, and emphasizing the negatives in evaluation rather than positives. So those would be classified as negative behaviors in terms of supervision. Next slide. So that wraps it up, and I hope it gave you some insight and opened your mind, those of you who don't seem to experience much supervision, to what good supervision looks like, and hopefully you can have some ideas of how you might be able to inculcate it into your own departments and certainly your own practice as you supervise juniors. Thank you very much.
Thank you very much, Dr. Griffiths. That's brilliant. Okay, so we're now going to take a slant and look at mentorship because people do use them interchangeably. So why have we differentiated it? We're going to do the similar thing as we've done with supervision. Describe what it is, what effective practice looks like, what the challenges and unmet needs, reflect on your own practice. And I've got a lovely diagram out of one of the papers in the references that hopefully gives you a contrast of the nuanced differences between supervision and mentorship. So what is mentorship? It's described in clinical medicine as a dynamic, context-dependent, goal-sensitive, mutually beneficial relationship with an usually and pretty much always between an experienced clinician and a junior clinician. And it focuses on advancing the development of the mentee. So it's very broad. It's about developing the mentee. I quite like this little sort of crossword puzzle thing. I've never really thought about that, but it fits very well. So you want to improve, you want to develop. You can have training in it, but generally mentorship is now separating out. It's not so much to do with your clinical progress. That's the key thing. And it's really a coaching model that's used to inspire mentees to achieve their goals. And it's not so formal. So it's less prescribed than supervision. You're not aiming to pass a point to become a dermatologist. It is about a relationship where you can have a conversation about the things that the resident is struggling with. You choose your mentor. They're not allocated to you as part of your residency or training program. So you will reach out to anyone you feel, and it's very important that it's someone that you choose that you feel that would be a good mentor for you. The mentor is not there to be your assessor. It's a crucial difference. They do not sign off and determine your progression in your educational development, but they support your self-assessment, ask you questions and ask you to look at yourself and your performance, say, where are the areas that I think I'm doing well? Why am I doing them well so I can keep doing them? And where are the areas I'd like to improve? It's really important that this is a reciprocal relationship. So where you've got supervisor and supervisee, it is a hierarchical relationship because they are your assessor and they are going to make you, determine progression points. Whereas a mentor relationship is much more flattened. And that is context specific, it's culturally dependent. We don't have the same cultures in different parts of the world, which is a great thing. But in terms of clinical practice and the aim of producing highly effective, high quality doctors, mentorship and its flattened hierarchy are key. And that's a really important challenge for us as doctors who are mentors, who are leaders of education in dermatology, because that is a challenge that medicine has had for age-old, hundreds of years. We are hierarchically driven. It has worked very well for us in the past. What the evidence is now showing with the changed expectations of patients, where they're not looking for paternalism so much, they want to have control of the decisions about their health, that actually we need to change ourselves. And that's a big ask of the medical profession. It's a big, big ask of the medical profession worldwide, but the evidence is quite clear that this leads to better outcomes for patients. And that's fundamentally what success, I would argue, looks like for us as doctors. So, the evidence around mentorship is really important. The difference with supervision is that mentorship actually is starting to show that it affects the career choice. So what subspecialty may go into, that I think goes without saying. A good supervisor will probably have that same, but the mentorship relationship may be shorter rather than longitudinal, maybe 6 months or a year. But a positive relationship can positively affect career choice. It also affects retention of doctors in the workplace when we're so short of healthcare workforce around the world. It also influences academic output of that trainee, because if you flatten the hierarchy and they've led the agenda, they are much more successful with their academic output. And interestingly enough, mentorship has a really big role to play in commitment to the organization that resident works in. Where there have been formal mentorship programs in hospitals, they have found that the workplace environment is healthier, happier, and more importantly, the staff stay there. And if you're thinking about residents who are in training, they are more likely to stay to move to become consultants in more permanent positions. And if we're in a world which is moving towards robbing Peter to pay Paul, so Dorian, you say there are not enough dermatologists in Tanzania and they're not staying. Well, got to look at all aspects of workforce retention in dermatology to support the population that need us. So I like this quote. The scarcity of formal mentoring programs is by striking contrast with the overwhelming evidence of its importance. So essentially, we're starting to realize the power of mentorship. And we gradually, I see if we had this conversation in 10 years, 15 years time, I think you would see a different conversation about mentorship, and it would become a much more familiar, understood aspect of our roles as senior doctors. At the moment, it still sits more in the apprenticeship style model than the actual formal educationally evidenced arena. It is coaching style. That means you need to have the 3 A's as a mentor to learn to be available. You have to be analytical. In other words, listening very actively to the mentee about what are their problems and asking them questions. The job of a mentor is not to problem solve, but to encourage the resident to problem solve themselves and develop that independence of thinking and mind around what they need to face as a practitioner. And the active listening resident-led agenda. And it's a safe space. In other words, no discussion in a mentorship conversation should affect or be fed into decisions about the progress of the mentee. As a consequence, your mentor does not need to be a dermatologist. Your mentor does not need to be a doctor even, really putting it out there. I've not seen models where they do that, but now the literature is starting showing pockets of areas where sometimes actually having a mentor who's another type of clinician is an area that people are venturing into. Why does it need to be a doctor? Because the mentor's relationship is not about your performance. It's about you getting the best out of yourself if you're a mentee, and them achieving or encouraging and supporting that. So what are the benefits and what are the things that mentors and mentees look for? What is expected of them? In the literature, the evidence that shows it's effective is a mentor who supports the mentee's ability to network, provides guidance and advice about developing their research intents, not just on their own agenda, but what the trainee or resident's agenda is. And that can be really difficult because when they start talking about research that they wish to be doing, really they've flipped into a supervisor role. And a mentor's really your critical friend, your critical colleague, your critical big brother or big sister. Say, well, is this really right for you? Why is it right for you? What would be better about this? Those sort of questions. And offering that professional support about areas you're having difficulty, experiences you're having difficulty. As a consequence, mentors will, of course, provide emotional support through those conversations. But from a mentee's point of view, a good mentee, a mentee who gets the most out of it, is respectful of the fact the mentor has dedicated time to you and given that time and availability, and that we're not demanding things from them, but respecting that this is a mutually agreed contract or conversation. An effective mentee exhibits clear ownership and takes responsibility for how to move things along and shows initiative. Now, these are very similar to what a good doctor is. So we're not talking about anything cutting edge, anything revolutionary. We're simply talking about putting boundaries and understanding the relationships that you have with your mentor or your supervisor and how they are subtly but importantly different. Okay, so what are the challenges? I think this applies to supervisors as well, but the key things, and Tammy's touched on that, is protected time for your mentor. It is very difficult, and Monty, you alluded to this, unless there is protected time, and we do need to voice that. As dermatologists, we need to keep voicing that actually we need that protected time, and it is hard, but it shouldn't be forgotten that unless we do that, we are not going to produce a dermatologist of the future. We are not going to have a dermatology service in areas that are particularly short. Unless you have those role models in place for the reasons the evidence is showing about what impact it has on mentees. It does require organizational buy-in, and it is difficult because employers do not see the benefits directly of mentorship. It is not like you're calculating numbers of patients seen or money brought in or all those other aspects of clinical care. And that is also partly because employers are not used to collecting the right type of data. They do it in quantity rather than quality, which is actually because of my mentorship experience, I want to stay in the organization. Because of my mentorship experience, I have produced this and this and this in terms of my research, because it's a long-term benefit. You have to wait 4 or 5 years for the benefits to show through on the mentee. I'll give you an example of that is that at Manchester, I run the Dermatology International Fellowship Program for a number of years. Now, having run it over for 10 years, it's really taken 10 years to show the data of those trainees who have come from abroad to work with us, have gone back to their own countries to become leaders of service, to set up new services, and then to go on and to be effective senior managers because they've had the experience. That takes time to collect that data. And unfortunately, employers, particularly in public health, like many other areas, we're strapped in with resource, want immediate results. But we should be advocating for the long-term benefits where we can. So this is a paper from Andrew Mellon and the team, and it describes it from a pediatric dermatology, pediatric perspective. But I really like this diagram, which kind of highlights differences between mentoring and supervision. So if I can just give examples of the supervision, which is the top one, the trainee, the issues and needs, and what kind of things a trainee inputs into the relationship is they have a stage of training and they have prior experiences that they bring to the table. That's their context. But they are required to meet standards of the college or the supervisory body, and the output that you're measuring is their performance. In contrast, in a mentoring relationship, really you're going to be covering the emotional and professional needs, and it's led by the mentee rather than the formal structures of the college. So you may talk about career progression, you may talk about modeling behaviors, talk about enhancing your networks, and really delve into self-awareness and navigating those things that we don't discuss in curricula, like the institution, the organization, the health structures where you practice. Those are the sort of things that will be slightly different. So you can see that there is a tendency for supervision and mentorship to overlap per se, but it's important to know the difference because it is a different relationship because of that contrast between performance and development, and they can be at conflict. So if we look at the supervisor's perspective, the topics and approach, it's likely your supervisor's allocated, just to summarize this, and they will more likely take the lead in the supervision to make sure that you meet your outcomes for your training and your program, okay? And they do have to provide a report at the end without doubt for allow you to progress. Whereas in a mentor relationship, it's about developing the relationship. It's about the interaction between that two individuals and helping the mentee identify their needs and negotiating mutual time and availability. It is really quite different what the purposes are. You are there to support, to coach, to encourage, to motivate, and to challenge not just clinical knowledge, but give them a space to challenge their own assumptions about how they're going about in their medical career. So there's much more of a visionary and an aspirational aspect to mentorship than there is to supervision. Supervision really has a finite point, which is the point of progression to becoming a consultant dermatologist. There's some things in the chat I'd just like to pause there. Okay. That's very challenging, but hopefully you could release some mental. I'm just reading the chat, guys. Monty's written, it's the educational leads in your program who need to rebalance the demands of service training. It's a constant struggle, but a cohesive and consistent training voice should be heard. I think you're right about that, Tammy, and it can be difficult. And that's why we bring topics like this for discussion, because it is a very real challenge. And we should continue to be discussing these educational topics and looking at the evidence of why we're doing things. So I've got a question for you, as you've seen here, that I've changed the slide to. Given what we've described about overlaps and differences between supervisors and mentors, do you think that your supervisor and mentor should be the same person? Can they be the same person? I'd like people to consider that and put their thoughts in the chat. I'm just going to give you a moment to do that because I know you'll be typing. Let's see if I can make the chat better. So Isabel says, in my opinion, they should not be the same person. Monty says, it depends on the relationship with their supervisor. Preferably not. I think they can, but to limit bias, it would be good to be separate. So yeah, so that's, I think, the key thing is that's why I think it's so important understanding the different roles. The literature doesn't actually say one or the other. I think it's more about knowing those limitations, knowing what the biases could be. The point also is, I hope you can see, is that you do not have to choose your supervisor as your mentor. As a trainee, you can approach other people. And there's no harm in asking. If you don't ask, you don't get, is that phrase that we have, in this part of the world. So it can work if, when you start the relationship, it is clear when you're talking about your performance, and that you actually are separate when you're talking about other things. It can be difficult if you are a supervisor and mentor, and in making sure that you retain the confidentiality of the mentor relationship in topics that should not be discussed. And so we as supervisors need to articulate, this will not be discussed outside this discussion, outside this conversation. And you can put verbal boundaries in your conversation. But what is really fundamental and important is to have that discussion at the beginning in your first few meetings and explore that. So thank you very much for answering that. And I hope it's given you food for thought. So a little bit more. I just want to get a sense from yourselves, having talked about this now, is that, were you guys aware of these sort of differences? Has this information and this discussion hopefully formalized some things? Is there something you've learned? You've discussed some of the challenges, but I'd probably go to the first question, the last one now, is, were you aware of these sort of differences? And are there things you would do differently in your respective roles, having listened to this webinar and the discussions we've had and seen other people's opinions? So if I could ask you to put in the chat, please. Tammy, while people are thinking about this, what are your thoughts about the supervisor mentor and whether they can or should or shouldn't be in the same person?
Well, I think the concept of mentorship is much broader. As you said, it might not even be a doctor. So I think we have mentors in all different spheres, and you might have more than one mentor at once. So if you think about an loosest term, a mentor is somebody who you go to for some advice, who you might be struggling with a problem and you can speak to them safely, and also who inspires you. So there may be many people that you work with who aren't your supervisor, maybe not even in medicine, who inspire you. So I think you definitely, definitely separate the roles. And I have worked with trainees and been their supervisor, but also feel I provided them with more mentorship than actually being formally in a supervisor role. But it's very dependent on the relationship, on the personalities involved. But if I'm acting as a supervisor, it's very clear I need to get this data, to show this evidence, so that at your appraisal, you will progress to the next level, and it's much more formal and structured, where the mentorship role is much less formal and more supportive, really, to allow the individual, the trainee, to answer their own questions and just support them in reflection. So I think it is possible, but it depends on the relationship, and there has to be some understanding, and it's really whether the trainee would feel comfortable disclosing information, that knowing that I was their supervisor. So I think those boundaries need to be clear.
Thank you very much. I think you made the good point about mentorship is not just about the person in your workplace. We do have mentors outside our workplace. The other thing is, you can change mentors. You can, as you grow and develop and you need different things as a mentee can change their mentor. I probably have different mentors at different stages of my career, but even in recent years, in the last 2-3 years, as I became a professor, I've changed again with different mentors, because you're looking for different ways and different opinions and different perspectives on how you wish to develop. So remember that point of it as well. Okay, one person can play 2 roles. Yep, I think, so it's more being really clear about what the roles are. So I asked the question, I haven't had any in the chat, and I'm wondering if there's how will you think differently about your role as a mentee now, for those of you who are mentees out there? Having had this discussion, I just want 1 or 2 little succinct little pieces of thoughts from people. So I'm going to give you 1 more minute, and then we're nearly finished off. So really interesting. I always thought my supervisor was my mentor. He never was, and that's what we missed a lot in our career. So I'd say to you, Richa, how would you've still got opportunity moving forward. So have a think about actually, how can I now seek a mentor? Yeah, great. Great, Simon. So great to hear these thoughts. I hopefully it's just giving this webinar is giving you space to think about this issue that we don't give ourselves time to think about, and yet is so fundamental to enabling ourselves to develop, whether it's as a mentor or as a mentee or as a leader of educational programs. What could be done? How can we do it bit by bit? A very wise professor of medical education said to me, when the challenge seems overwhelming, is how do you eat an elephant? And I did look at him and say, I don't understand what that question is. And what he simply meant is one bite at a time. So pace yourselves, but give yourself space to think about some of these crucial issues. So maximizing your development. It's just what I've said. I've preempted my own slide, guys. What can you do? Ask yourself when you're going into this relationship, what is the purpose of the relationship? In supervision, if the relationship is supervisory, be clear on the expectations and requirements to meet the educational needs. Now, that may come from the supervisor, but if you are a supervisee, a resident, then ask if you're not clear. And do not feel that the burden is all on yourself to know everything. If that was the case, you would be the head of the teaching program, not the resident. Okay. We have done the Alliance has done a webinar on effective feedback models, but they are essential to make this effective. And I wanted to bring up another point, which is culture of failure. It goes back to that first slide with the successes and the failures and the obstructions and things. I do think as a medical profession, as a healthcare profession, in any profession, we as human beings need to be kind to ourselves. We have a culture of failure is bad. I would challenge that. The literature challenges that. We have to fail in order to succeed, because the best and most effective way of learning is to not quite get it right. So a challenge out there in dermatology education, for educational leaders, for dermatologists, for dermatology residents, as you become the leaders, is to really think about what the purpose of failure is and how failure is actually an opportunity to success. And we do shoot ourselves in the foot. We do feel that if we've not succeeded in our training or at some progression point that we're a terrible failure. Actually, you know, we've all experienced that. We need to experience that to be the best doctors for our patients. So I just particularly wanted to emphasize that. So mentorship, we've talked about this. We've made the first point to Dr. Griffiths and I several times, so I won't emphasize that. But also, if you are in a position, volunteer as a mentor, look for mentoring programs to develop these skills. There are many online out there. It is an extremely rewarding role to play, but I may be speaking to the converted because you've attended this webinar, but have discussions. If you haven't already, seek to. At some point, if you have the momentum and talk around, there's a momentum, it's established one in your organization, your region, your country. It is different to supervision. It does have benefits to the healthcare system. And there is data out there that can support that if you look at the educational literature. And I think really the final thing to just say is thank you from Dr. Griffiths and myself and the International Education Alliance. Thank you to GloDerm Trainee Committee. And before we completely finish, I just want to read in the chat because I don't want to miss anything that important points to raise, if I say. Isabel makes not everyone is willing to be a mentor. That is true, Isabel, in which case they shouldn't be a mentor. It has to be somebody who wishes to do it because it's really important that it's something that they feel comfortable with. Monty, go ahead and send emails to mentors. I like the enthusiasm. So Dorian talked about I knew there were two different things, but I didn't know where supervision ends and how far mentorship goes. And I now understand as a mentee that I need to have more initiative. Can someone have more than one mentor? Absolutely. I currently have at least 4, some of them formal, some of them informal. And Dr. Griffiths knows she's one of my informal mentors. So I have one in this webinar.
It's mutual.
So the answer is absolutely, because it's determined by you, Dorian. It's you who determines a mentor, you who determines what needs you have. So it's not restricted. Can someone who is not practicing at present apply for mentorship program at Glowderm? Richa, I don't actually know, but we can take that back, can't we, Rafense? We've actually got a meeting coming up soon and I sit on that committee. So Richa, don't know, but we can look out for that, okay? And we can ask the question. Thank you for asking it. I'm just reading Daniel's reflection. Supervision is more guidance towards a specific objective you need to achieve in a duration of time frame. The mentorship is more broad. Yep, absolutely. Claire, lovely of you to join us. So we've got Dr. Fuller, who is one of the leading proponents of global health in the world, and a colleague. It's lovely that you've joined us. Thank you for your comments. Okay, so I think that's it from us. Thank you very much for participating. And I'd like to hand back to Rafense and Dr. Fuller about the mentorship program, if I may.
Thank you so much, Dr. Singh and Dr. Griffiths. What a wonderful talk, very informative. You know, we talk about mentorship and supervision, but you know, tonight you've clarified most of the things that, you know, what one would ask themselves. What does mentorship mean? What does supervision mean? So thank you so much. It was quite an interesting talk, and I hope that you will give us such, you know, talks in the coming future. We'll build on the one that we have. And we actually have come to our end of our webinar. Before we leave, I would also want to introduce you to our mentorship program, Glowderm mentorship program, where we're looking at developing future leaders and change makers in global health, dermatology from low resource setting. So the applications are now open, and the deadline for application is from the 1st of 2022. And the most important aim for this mentorship program, or even the period, is to enhance the mentee skills related to the global health dermatology, including on how to write research paper, communication skills, how to write a peer review, setting up global health programs and initiatives, and also learning how to build a career incorporating global and/or community health. So applicants will be selected through a competitive process. So you are welcome to apply. And I think this will be quite a nice initiative that one can actually join. Thank you so much, everyone, for joining. And it's a pleasure to have both speakers, Dr. Tamara Griffiths and Prof. Mini Singh. Thank you. We really appreciate for your time in preparing such wonderful presentation for us. Yeah, I think this is it. Thank you all.
I think I was just going to say that thank you very much for having us. And if anybody manages to go to World Congress, then we'll be there as well. So, but thank you very much to Rafense and all the Glowderm team for giving us this opportunity to discuss this, I think, really important issue. So take care of yourselves, and it was lovely to meet you all virtually. Bye for now.
Bye, thanks.